This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System titled Long-Term Outcomes of Pediatric Craniopharyngiomas, a comparison of two large international series.
This is a topic that hits home for anyone in the field. Adamantinomatous craniopharyngioma, or ACP, is really one of the most taxing pathologies we deal with in pediatric neurosurgery. It's not just about the technical difficulty of the resection. It's that impossible balancing act between pursuing a gross total resection and protecting the hypothalamus.
Exactly, Dr. Aris. And this study provides a unique perspective because it's a retrospective observational look at two very different tertiary centers, Great Ormond Street Hospital, or GOSH, in London, and the University of São Paulo, or USP, in Brazil. They looked at 123 patients in total, 71 from GOSH and 52 from USP, treated between 1997 and 2023.
That's a significant time frame, over 25 years of data. When you have two major centers like this, you expect to see variations in management, and that's where the real lessons are learned. Let's start with how these patients presented. Were the cohorts similar at the starting line?
Interestingly, no. There were some notable differences right at presentation. The USP cohort in Brazil seemed to have more advanced symptoms. They had significantly higher rates of growth hormone deficiency, about 62.5% compared to only 35% at GOSH. They also had more visual deficits at initial presentation.
That's a stark contrast. It suggests a possible delay in diagnosis or perhaps a different biological behavior in those specific populations. What about the imaging? Did the tumors themselves look different on the pre-op scans?
They did. This was one of the most interesting findings for me. The GOSH patients presented with predominantly cystic lesions. About 76.7% were cystic. Meanwhile, at USP, solid tumors were much more prevalent, making up 75% of their cases.
That is a huge clinical distinction. As we know, a large cystic craniopharyngioma often allows for different surgical strategies, like simple aspiration or Ommaya reservoir placement, compared to a rock-hard solid tumor that's adherent to the small perforators of the circle of Willis. Did the study use a specific grading system for the hypothalamic involvement?
They used the Paris grade. And surprisingly, despite the USP patients having more solid tumors and endocrine deficits, the Paris grade for hypothalamic involvement was actually higher in the GOSH cohort.
So GOSH was dealing with more cystic tumors, but those tumors were more intimately involved with the hypothalamus. That brings us to the surgical management. How did the two centers approach these differently?
This is where the management styles diverged. While the rates of growth total resection, or GTR, were actually similar between the two groups, the alternative strategies were different. At GOSH, they favored cyst aspiration combined with radiation. At USP, they were much more likely to perform a debulking procedure.
That reflects a very specific philosophical divide in neurosurgery. The GOSH approach in this series seems to lean towards minimizing direct surgical manipulation of the hypothalamus by using aspiration and adjuvant radiation, whereas USP was more likely to go in for a subtotal removal or debulking. What were the functional results of those choices?
The data suggests that the GOSH strategy paid off in terms of morbidity. The post-treatment hypothalamic scores were significantly better in the GOSH cohort. We're talking about things like hypothalamic obesity and metabolic dysfunction, which are devastating for these kids.
It's the craniopharyngioma trade-off. You spare the hypothalamus, but what happens to the tumor control? If GOSH was doing more cyst aspirations and less debulking, did they see more recurrences?
They did. The study shows that patients at GOSH had earlier recurrences, averaging around 25.5 months compared to 37.4 months at USP. So by being less aggressive surgically to save the hypothalamus, they saw the tumor come back sooner.
This is the crux of the debate. Do you risk the child's metabolic and endocrine health for a longer progression-free survival, or do you accept a higher recurrence rate to give them a better quality of life? It's a 12-month difference in recurrence-free time, but the hypothalamic preservation could mean a lifetime of difference in terms of obesity and social integration.
And the researchers dug deeper into what actually predicted a longer progression-free survival across both cohorts using a multivariate analysis. They found two main factors. First, the extent of surgery, specifically achieving either a subtotal or gross total resection as opposed to just a biopsy or aspiration, was associated with a significantly lower risk of progression. The odds ratio was 0.17.
Which makes sense. The more you take, the longer it stays away. What was the second factor?
Older age at diagnosis. For every year older the child was at the time of diagnosis, the risk of progression decreased. The older kids seemed to have a more favorable course.
That's a common observation in pediatric neuro-oncology, but it's vital to see it confirmed in such a large series. Now, Laura, let's talk about the long-term follow-up. These weren't just short-term snapshots.
No, the follow-up was quite robust. The mean follow-up at USP was 10.1 years, and at GOSH it was 7.5 years. This gives us a real sense of the long-term outcomes the title promises.
Let's look at the Paris grade again. For our residents listening, why is it so important that the post-treatment hypothalamus scores were better at GOSH?
Because hypothalamic injury in ACP isn't just a surgical complication, it's a life-altering syndrome. When we look at the study's results, GOSH's focus on avoiding aggressive debulking in favor of aspiration and radiation directly correlated with better functional outcomes. Even though they had worse hypothalamic involvement on presentation, that higher Paris grade we mentioned, their post-op scores were superior. It implies that the surgical trauma is often what pushes these kids over the edge into hypothalamic syndrome.
And that's a powerful argument for the less is more approach in the modern era, especially with the precision of current radiation. But we can't ignore the USP side. They were dealing with more solid tumors. You can't just aspire a solid mass.
Exactly. The paper notes that 75% of the USP tumors were solid. In those cases, the surgeon is often forced to debulk just to relieve pressure on the optic chiasm or to reduce mass effect. You don't have the luxury of a simple cyst drainage. This might explain why USP had longer progression-free survival. They were physically removing more of the tumor mass because the pathology demanded it.
It really highlights that craniopharyngioma isn't a single entity. A 5-centimeter cystic lesion is a different surgical disease than a 2-centimeter solid calcified mass.
To summarize the key stats for our listeners, we have 123 patients. GTR rates were similar. GOSH had more cysts and used more aspiration RT. USP had more solid tumors and did more debulking. GOSH had better hypothalamic outcomes but earlier recurrences. And finally, GTR/STR and older age were the champions of progression-free survival.
It's a masterclass in the nuance of pediatric neurosurgery. You can't just look at the recurrence rate in isolation. You have to look at the child behind the scan. If I can give a child an extra 10 years without hypothalamic obesity at the cost of an earlier second intervention, many parents and surgeons would take that deal.
The study really emphasizes that management should be tailored not just to the tumor's location, but to its consistency, solid versus cystic, and the baseline hypothalamic involvement.
Well, this has been an illuminating discussion. It's studies like this, comparing international cohorts over decades, that truly help us refine our surgical philosophy. Any final thoughts from the paper, Laura?
Just at the Paris grade and the focus on functional outcomes like pituitary function and cognition are becoming just as important as the all-clear post-op MRI. The goal isn't just to treat the tumor, it's to protect the child's future.
A perfect note to end on. Thank you, Dr. Laura, and thank you all for tuning in to the Neurosurgery Hub podcast. We'll see you in the next episode.
Goodbye, everyone.